Is that right? So that's the most important thing is the oxygen consumption. So start at rest and start like raising up slowly, and we'll see like when exactly in what exercise, okay? And the other thing that we talk about is the CO2 production, which we say the VCO2. So as I consume oxygen, I will start producing carbon dioxide. Is that right? That's the normal thing. So, and the carbon dioxide, when I start producing carbon dioxide, I need to get rid of that carbon dioxide. How can I get rid of that carbon dioxide? By ventilation. So I need to increase my minute ventilation. Okay. So that's like when, like during normal physiology, that's what will happen. And the other thing that when, like normally, all of us at the beginning of exercise, our cells start like producing by glycolysis, giving us ATP, goes to the Krebs cycle, and it reach a point that we cannot like have sufficient ATP by just the aerobic. That's normal. So I have to produce more ATP from the anaerobic spot, which is like usually forming lactate, and the lactate will give us ATP to use. But the thing is, yes, that's, I know that, and that's in medical school, Dr. Megri. Like, we're not here today to tell me like the normal physiology that we know, all of us in this room. So, but what we need to know is when is the anaerobic threshold happen, and when the patient reached the point that he passed the, like he is like past the stage what we call the isocapnic stage. Okay, so if we draw a line, if I draw a line in here, that's when you say like that's the early exercise, that you're exercising and you are getting like the enough like oxygen consumption and producing producing carbon dioxide and having normal minute ventilation. If you look at the lines, it's almost close to each other. Is that right? The way how it rays before this line. So then if I draw another line, this is what we call the isocapnic stage. What is the isocapnic stage? So when we start producing more lactate, if you see the lactate is start going up, when you start producing more lactate, what we need to do, we need to buffer that lactate. Is that right? And the normal buffering for the lactate is we're using the bicarb. So the bicarb will attach to the extra hydrogen ion, and that will give us H2O plus CO2. Oh, wait, so now I have another CO2. It's not from the regular production from the cell. So how can, so the CO2, if you notice in here, it started to go higher, more comparing to the VO2, the CO2 production. So how can I get rid of that extra CO2? So I need to increase more minute ventilation. Is that right? So that's what we need to do. So if we see in here, the CO2 and VCO2 both are raising, but the CO2 production is raising higher than the VO2 production after we passed the isocapnic stage. So like, so if I do a ratio in here at rest, my VCO2 to VO2 ratio will be like around 0.8. That's at rest. As long as I go higher and higher in my exercise, that ratio should increase. Why is that? Because the VCO2 is increasing. So if I take the ratio from the VCO2 and VO2, which we call the RER, the respiratory exchange ratio, so that will increase. Is that right? And from the rest, it was like 0.8, and that will start increasing. And how do we know that we are in the anaerobic threshold? When it's like it increase and it's become like 1.15 and higher. That's, we know like it is like done. The VCO2 is, that's right. The VCO2 increased a lot. So that's what we call the RER ratio. Okay. Is it clear to hear? Clear like mud? All right.
So
Yes.
so the 0.8, that means the production is more than the consumption is more than the production.
You are right. That's right.
And at the end of the exercise, the production
Not the end.
like
Like it's starting from the anaerobic threshold and going up.
the production will be more than the consumption.
That's right. All right. So as like during physiology, so we have the right and the left side of the heart. So during systole, we are filling our atrium, and during the during systole, when we have the flow from the right ventricle to the lung to get oxygenated. Is that right? Like we'll like all the blood will get full of oxygen, and then it will go to the left atrium, and then go to the systemic, and then go to the other systems. So during exercise, what will happen is I need more flow. Like I'm exercising, I need more flow. So what will happen is the pulmonary flow will increase. So I have more flow, that's normally. And our dead space will decrease. Why is that? Because I have more flow to the alveoli and everything, so the dead space will go down. So that's normal with exercise. My stroke volume will go up and the heart rate go up. Good. So the stroke volume and the heart rate go up. That's like an easy answer. But as a pulmonologist answer, yes, both of them will go up, but I will reach the point that the stroke volume will start plateauing and the heart rate will like continue to go up, but it's not very fast. Why is that? Trying to compensate, trying to increase the like what's the cardiac output equation is? Stroke volume times heart rate. So I can increase the cardiac output by stroke volume or heart rate. If I ask Shaheen now to start running, his stroke volume stays the same and his heart rate goes to 200. What does that mean? He's trying to increase the cardiac output only by the heart rate. So there's something wrong in the heart. Is that right? It's not normal. And the other thing that we have, the tidal volume will increase and the respiratory rate will increase. So those are the same, exactly the same thing. The tidal volume start increasing and then it will plateau. The respiratory rate will increase higher. So if my respiratory rate is increasing without increasing my tidal volume, then there is a problem with my lung. And the opposite, if my like respiratory rate increasing and tidal volume goes down, still there is a problem with my lung, and we'll talk about that in the future slides. Okay. So now we'll go to the point that we have the stress, we have the cardiopulmonary stress test or the cardiopulmonary exercise test, and how we should like start the interpretation. First of all, as a physician, you have to be in the bed, like in the room with the patient while they are doing the test, because you are the one who will make sure that the patient is safe during doing the test, as well as you are the one who can, as Dr. Jasmi said that last lecture, that like you make sure that you're gonna push the patient to the limit. Like you're gonna push the patient, but make sure that you are safe pushing the patient to reach that his upper limit. Because if he does not or she does not reach the upper limit, then you cannot interpret the test. So that's why as a physician, you be inside the room and watching. And we said like you are watching the EKG, watching the oxygen saturation, watching the patient himself and asking the patient chest pain and stuff like that. That's very important to do during the test. But the first point is the performance and the effort. How do I know my patient had a good effort? That's the first thing that I should look at, like any test. And you have all of these things, guys, in your cheat sheet. Is that right? Like this, the one that I sent to you, that's like all of this, it's in there, but I want you to understand it, just not just to read it. So the first thing is I look at the workload. The workload. What's the workload? The workload, which we calculate with watts, that's the energy that the patient will produce against the resistance that I give you during the bike or the treadmill, and mainly the bike. So when I ask the patient to keep his cadence on 60, and I ask the patient like to trying to pedal with the bike, and I increase the resistance. As we mentioned last lecture, we said there is the resting stage, there is the battling stage, and there is the loading like incremental stage, and this recovery stage. Is that right? So when we start like battling and you start increasing the resistance slowly, that's what will happen, like the energy will produce. And according to the patient age, gender, height, weight, we can have the prediction how many, like what's the predicted watts that the patient can reach. And if you look at here, that's the predicted watts. So this patient, they said like his predicted watts is 204. That's according to his age, weight, and everything we mentioned, okay? So to know that this patient reached the performance, that's one of the criteria that we look at, which is we look at the maximum watts, like in he did during the VO2 max. If you look in here, VO2 max, so the maximum watts is 155. So we'll take the 155 divided by 204 and take see like what's the percentage of it, okay? So normally we are looking at least 80%. So if the patient reaches 80% of the like predicted watts, that's a good performance. If it's like 70, 75, we still can take it, because it's not only one parameter. We have other parameters that we're going to look at. And don't forget that we are in the room, is that right? So we can judge if the patient did his best or not. Okay, so that's the first number you need to memorize. Got it? The second thing is, sorry, looking at the test itself, there is like the graph that will give us like looking at the VO2 and the watts. So this graph was in the test like Mina had done, which you can see in here, it's going up, like steadily going up, like his watts, his workload is going up. And you can see in here, we have the works with watts, and that's what's the maximum was 155. Okay, so that's for the watts. The next step will be looking at the heart rate. And we as all know, like, oh, what's the I'm 37-year-old, so what's my predicted heart rate? How can you calculate that?
210 minus.
Not 210,
220 minus
220.
There's
That's right.
two equations. The one in the ATS CPET reading, they recommend 210 minus 0.65 times age.
That's right. And they said this is like more accurate, but it's not that a big difference between the 220 minus your age. And you are 100% right, Mina. So those are the equations that I use. Is that right? So if I do that and like I look at my maximum heart rate, which is in here, that's the maximum. Is that right?
Yeah.
Like I need you to like get used to look at the report itself. So maximum heart rate, it was, where's the mouse? 148. And we'll take that out of 186. How much the patient did like 80%. Okay, so 148 divided by 186 was like 80% of it. So what we look at 80% or higher. So that's the normal like response, that the patient had a good performance, that he reached 80% of the maximum heart rate. Is it clear? Good. So then the last thing that I look, before the last thing, we look at the RER. Remind me, what's the RER, guys?
The VCO2 divided by VO2.
Awesome, good. That's the respiratory exchange ratio, which is the ratio between the CO2 production and compared to the VO2 consumption, as Shaheen said. Okay, so, and we said at rest will be like around 0.8. And when we reach the anaerobic threshold, it would be like more than 1.15. And our target to reach more than 1.5. And if we look at here in the maximum at the V2 max, it was 1.17. So we reach the target that we are looking at. All right. So those are the three main things to look at the performance. If your center does a lactate, which is an ABG and lactate level, then that's, you can look at it as well. If your lactate was like 1.5 at the beginning of the test, and then your lactate went up to 6 or 7, so you know that you reached to the anaerobic threshold because your lactate was going up. All right.
Is a cut value for?
I don't have like a cut value, just like increasing in lactate. That will, maybe there is, that I didn't know. So, but there's no, as I know, there's no like a cut value of the lactate goes, like if the lactate doesn't go up, like if the lactate started going up, you are in an aerobic threshold. Okay, so those are the three things. So performance, three things. We look at the watts, we look at the heart rate, and we look at the RER. Got it? All right.
In this patient, at rest it was 0.9, and after the anaerobic threshold, it's 1.17, right?
That's right. So that's the good response that we look at. So this test was had a good response.
Okay.
Always put in your mind, you're gonna take a history from patient and review medication. Why is that? Because if patient on beta blockers, sometimes he will not reach his maximum heart rate, but he will reach maximum watts and maximum RER, and the lactate will go up, but he did not reach the heart rate. So that's why you need to have like multiple different things. You are watching the patient, you are looking at all of these things, not just one number. All right. So when we look at the test here in our center, in our lung center, so we divide the test like to the metabolic or the oxygen consumption, which is this part of the test that you look at. And the second part will be the cardiac part. And the third part will be the lung part, the ventilation part. So those are, and there's a mixed part between the heart and the lung in the bottom of the test. So when I look at the test, after I look at the performance, I divide it to this way. I look at the oxygen consumption, and I look after that to the cardiac parameters, and then to the lung parameters. Okay, so I can cover that the whole thing in one lecture, but that's I'm explaining to myself, not to you guys. So that's why we'll divide it to multiple lecture. We'll talk only today about the cardiac parameters. I can just like keep talking and VO2, VCO2 and all of that stuff, and you will get out from here confused. But we'll, unfortunately for the third year, maybe we'll not attend all the lectures, but we can sit outside and do it for you guys. All right, so we will go with the first part, which is the oxygen consumption part. So, which is the most important part? It's the most important part. Why do I feel short of breath? Because my tissues start to have less oxygen consumption than normal. Like my heart, my lung, my muscles getting like oxygen consumption less than expected. That's why I feel like I have limitation with exercise. So how can I know from the beginning, the first thing, that he did a good performance? Yes. Okay, let's jump to the VO2. So I go to the VO2. And the VO2 oxygen consumption can be calculated in VO2 ml per kg per minute or liter per minute. Okay. So the normal at rest, if I like take now Katabi and check his oxygen consumption at rest, will be around 2.5 to 3. That's at rest. And I expected from Katabi when he do exercise, it will reach to 15 to 30. And if Katabi is Cristiano Ronaldo, it might reach like even 40 or 50. And that's like they trained to do that. Okay. But so now at rest, it was, if I look at here, it was 3.3 ml per kg per minute. And if we go by the liters, it's like around 250. That's the normal. So it's 0.25 liter per minute. Okay. So at rest, his VO2 is normal because he's not doing any exercise. Like he's not, doesn't have a problem while he's sitting doing nothing. Okay. Sorry. So when he start exercising, his VO2 start going up. Okay. 3.3, 11.4, 25.9. We have a predicted VO2 for this patient, which is like, it's according to his age, weight, and everything, that his predicted is 36.4. That's his predicted, okay? Is it clear till now? So the next step I need to look at, after I looked at the rest, I need to look at the one at the maximum. What did he do at the maximum? So in maximum here, he did 25.9. That's the maximum. That's the first thing we look at. And I need to look at this maximum out of the predicted. Okay, so normally maximum out of predicted should be more than 80%. So in here, in this test, it was 71%. Is that normal? It's not normal. So now, but Dr. Megri, if it's from the beginning, it's more than 80%. Should I continue reading the test? Yes, you can continue reading the test, but what he has, it's not sufficient enough to limit his exercise. If the VO2 from the beginning, like you look at the report, and the VO2 maximum is more than 80% of the predicted, any limitation this patient has, it's not sufficient to limit his exercise. Done. So you can, if like you don't want to read CPET in the future and you look at the test and, oh, VO2 maximum out of VO2 predicted, it's 85%. Oh, okay. Whatever you have, it should not be sufficient enough to limit your exercise. There's something else going on, deconditioning, something else. Okay. All right. But if it's less than 80%, that's abnormal. Clear? Okay. So maximum is more than 80% of predicted, and the VO2 at 80. What's that? So we'll have a one lecture just for like identify like the 80, the anaerobic threshold. Where is the anaerobic threshold? But in here, it's easy. Sorry, it's easy. Why is that? Because it's written in here. That's 80. Is that right? That's anaerobic threshold. So I look at the VO2 during anaerobic threshold, and I can compare it to the maximum predicted. So normal, the maximum out of predicted is more than 80. Is that right? And the normal at 80 out of predicted is more than 40%. Those are the normal values. If it's less than that, it's abnormal. And that's what I need to from you guys. Just start thinking of normal physiology and what's abnormal. And by time, if you understand physiology, you can read any CPAT, just knowing what's abnormal in this patient. Okay? All right. So after we did that, we looked at the VO2. So now we know the patient performance is is good, and we looked at the VO2, and the VO2 was not normal. Is that right? It was less than the like the 80%. So what's the next step? You can go with ventilation first and cardiac last, or you can do the opposite. But the way how I trained, I look at the cardiac parameters first. Okay?
Can I add a little comment?
Yeah.
So here in this patient, the anaerobic threshold, the VO2 at the anaerobic threshold was 11.4. For some reason our system gives for some reason our system, when you doesn't divide this over this,
To divide by this.
it divides by this, and this is not what it should. So like Dr. Megri said, it's VO2 at anaerobic threshold out of predicted.
Yeah.
Should be more than 40%.
Yeah,
I don't even look at the numbers on the right. So do the math by yourself. The divisions and everything, I do it by myself. Yeah. All right. So cardiac parameters. So we talked about the most important one, which is the heart rate. Is that right? What's the normal heart rate should be? 80% of maximum predicted. Is that right? So if I look at the rest, is there any benefit looking at the rest? Yes. I have one patient in my training during fellowship. So his rest was like 60 something. And then he just like stood from the chair going to the treadmill to do the test. And his heart rate went up to 100 something. So that's not normal. Is that right? That's like a POTS. Like it went up more than 30 from the baseline. That's postural tachycardia. So, and like, imagine that if he start exercising, where his heart rate will go. So that's like, you need to focus on these things. Oh, his heart rate at rest is 120. Oh, wait, that's not normal. There's something wrong. Maybe I didn't, like, maybe it's not safe to do the test from the beginning. So those are very important to look at. After I look at rest, I look at maximum. What did he do in maximum? 148. And 148 out of what? 186. Is that right? And that was 80%. So what are the importance of looking at the heart rate? So when we look at the heart rate, we said maximum is more than 80% of predicted. And we have the calculation for the predicted. So if the heart rate is more than 80% and the VO2 is more than 80%, that's normal test. So like if you have any abnormality in this test, it's not sufficient enough to limit your exercise. Okay, done. You got it?
Mm.
The second step, if the heart rate more than 80%, but your VO2 is less than 80%. So from the beginning, we said, if the VO2 is less than 80% and your heart rate is more than 80% of the predicted, so there is a problem in your heart. And most probably like you have like LV or RV dysfunction, or maybe there's something else going on, like cardiomyopathy or anything like that. We don't know. If your heart rate less than 80% of predicted and VO2 as well is low, so there is the options. The first option is sub-maximum effort. As we mentioned at the beginning, you did not do your maximum effort. That's why you were not able to reach the maximum, okay? Or you are in chronotropic like insufficiency because of medication or something else. Or you have a pulmonary disease. Oh, what do you mean? So my heart, it did not reach the maximum, and my oxygen consumption did not reach the maximum. It's most probably not because of my heart, because my lung, it did not allow me to reach the maximum, because I start having shortness of breath and limitation by my lung to give my heart the time to reach the maximum. Because normally, all of us in this room, if we are normal, what should limit our exercise? The heart, not the lung. Okay, the heart should limit exercise because I will start having fatigue and the flow will like not be sufficient to supply the muscles, and my lactate is going up and all of that stuff. But if I have normal heart rate, normal VO2, I'm done. If I have normal heart rate, low heart rate, less than 80, normal heart rate, more than 80%, and low VO2, so it's most probably cardiac problem, most probably. And if it's heart rate less than 80% and the VO2 is low as well, that's sub-maximum effort, chronotropic insufficiency, or pulmonary disease. Okay, that's the first step. Doesn't mean that we are done. We are finished with interpretation, but you put in your mind what you should expect to see in the test itself. That's the heart rate and the benefit of looking at the heart rate. Then the next step, we'll look at the VO2 slash heart rate. Oh my God, what's that? So when we look at VO2 heart rate, oh, we're gonna memorize something that we have never heard of it. Actually, all of you in this room know what's that. Okay, so all of us, we know Fick equation. Is that right? What's Fick equation? Anyone? Come on.
The VO2.
To check for the cardiac output. So what's the equation? That's the cardiac output itself, but what's the Fick equation? Like
VaO2.
So VO2 equals heart rate times stroke volume times oxygen content difference between the arterial and the venous.
That's right. Or if we do it in the opposite way, cardiac output equal VO2 divided by the oxygen content of artery minus the vein. Is that right? So the patient that we have in our test, as we mentioned in the first lecture, we said like he's not hypoxic. If he's hypoxic from the beginning and he's on oxygen, we will not do the test. So, and we say like most probably we are an adult physician, so we don't do pediatrics. Pediatrics, they have like possible like metabolic problems and muscle problems. So most of our patients, they don't have that. So the thing is like we can, that the difference between the arterial and venous, usually it's like we can neglect that. So we can say cardiac output equal VO2. And as Mina said, cardiac output equals stroke volume times heart rate. Is that right? So VO2 equals stroke volume times heart rate. Is it easy till this point? Is that right? Nothing except like simple math. So the stroke volume equal VO2 divided by the heart rate. And what we call the stroke volume in CBIT word, we call it the O2 pulse. So we removed the stroke volume and we said O2 pulse. So O2 pulse equal VO2 divided by heart rate. So if I look at the VO2 divided by heart rate, what does that mean? I'm talking about what? Awesome. About talking stroke volume. So when I look at this number in some tests, it will be O2 pulse or it will be with the equation itself, VO2 divided by heart rate. So this is the stroke volume. So we said stroke volume should start increasing with exercise. Is that right? And normally, like your stroke volume usually should be more than 10 ml per beat. That's your stroke volume. So when we look at the stroke volume, so it will start going up slowly. At rest, in here, it was 3, and then went up to 8, and then at maximum went up to 13. As well as the heart rate was going up. So as we mentioned before, the heart rate and stroke volume, both of them will start going up. And in one point, the stroke volume will what? Will plateau. And then the heart rate keep going up to just like give us more cardiac output. So when we look at here, the stroke volume in here was 13, which is more than 10. And the other thing that we look at the percentage of what's the predicted. So the predicted for this patient, they said stroke volume should be 15. That's the predicted stroke volume. According to his age, weight, and height, it's like 15. So when we look at him, he did like 13 out of 15. Means that what's the percentage of that? Like around 89%. What's the normal is the magic number for today was what? 80%. Okay, so 80%. Some textbooks are like an 85 and some of them like 80. So, but just like to be easy for all of us guys, more than 80%. All right. So O2 pulse usually increase early in exercise, then tails off as further increase in cardiac output will be due to what? To the heart rate increase. And normal said it's more than 80%. And this patient cardiac output and heart rate were normal. Is that right? Heart rate was more than 80% and cardiac output or stroke volume was more than 80%. Good. So we looked at 2 parameters in the heart. So if we look at this graph, which is one of the graph, and through the lectures, guys, when we look each graph by itself, it will be easy when at the last lecture, when we look at the all graphs together. So when you look in here, the red dots is the heart rate. The blue dots are the VO2 by heart rate, which is stroke volume. If you see in here, it goes up, the heart rate goes up, and the stroke volume goes up. At the end of it, like it's the blue dots start to plateauing in here. But the red dots is going up. Did you see that? The red dots is going up, and the blue start plateauing, which is like expected. And then during recovery, start going down. Okay, that's expected. So it's very important to look at the graph and the numbers. All right. So we talked about heart rate. We talked about the VO2. We talked about the performance. We talked about the VO2 and normal VO2 and abnormal VO2. We talked about the heart rate, normal and abnormal. We talked about the cardiac output and how we reach the VO2 over heart rate. Good. Blood pressure. What's the normal response to blood pressure during exercise? It will go up. Good. So if the blood pressure goes down, what does that mean? There is a problem with the heart. There is an ischemic heart problem. Is that right? You have a ischemic cardiomyopathy or ischemic cardiac problem that made your pressure to go down. So it's important when you are in the test as a physician, being physically beside the patient, when they are measuring the blood pressure, if the patient of the technician say, hey, the blood pressure started 145 and after 5 minutes we measured and it's like 110. Oh, wait. So there's something wrong going on, and we'll like see the patient symptomatic or not. If the patient not symptomatic, I can push another another few minutes. If it's like keep going on down, I will stop the test. Okay, and because it could be like a wrong measurement, something like that, we need to repeat the measuring the blood pressure. The other thing, if it goes up, so Dr. Megri, when should I stop? What's the magic number that we should stop? So there is no like a lot of studies saying, oh, it has to be stubborn here or there, but like usually expert opinion goes with 200. If the systolic 200, more than 200, you should stop. And if the diastolic more than a 90 or like 100, you should stop. So that's like normally, but you need to look at all the features, patient symptoms, stuff like that. But 200 is a big number. So if it reaches more than 200, you need to stop. So if you look at the blood pressure in here, it was 130 over 75, and it was going up. And there's like maybe went down by 5. That could be measurement error, but the accuracy, how to look at the blood pressure, I like to look at it in the raw data, and I will show you that at the end of the lecture, how to look at this, okay? Not just in this number, because this number will pick a number at the maximum, pick a number at the AT, pick a number at rest. But we have other data, will go like chronologically with the test itself, okay?
Is there any cutoff for the increase of the blood pressure, the normal response, like 20%, 30%?
There's no percentage wise, but there is like you should, it's just should go up.
Okay.
Yes, you don't have like, oh, it went up by this. If it goes up more than 200, so as we said, the CPET is not one value test. So you're looking for everything and trying to summarize a picture at the end of it. All right. So that's the what we said about the blood pressure. So we talked about most of the cardiac parameters, which the most important one is the EKG. So we are sitting at the bedside, is that right? And we have a resting EKG, and then the patient starts exercising. It's very important to look at the EKG changes. And it's the EKG changes that we learned from medical school. Like you have an T inversion, you have an ST depression, ST elevation, multiple ectopic beats, like stuff like can give you clue that there's something wrong going on in the heart. So while you're doing the test, you have to look at it, because you cannot judge on like depend only on the technician looking at the oxygen saturation, looking at the EKG, looking at the patient, asking the patient, because if you are over there and the patient starts evolving like T wave inversion or like ST depression or elevation, you're the one who should stop the test, and you're the one who can know these changes. Is that right? So it's very important to be there to judge on that while you're pushing. Oh, we not just push the patient to the limit without knowledge. We said push the patient to the limit with the safety zone. You have to watch this when you do this, okay? So that's the EKG. It's very important to look at. All right, last thing. This is a little bit like the last and the most confusing slide, okay? So when we talk about the right side, and as we mentioned that during systole, we have the blood flow will go to the pulmonary artery and go to like get the exchange with the alveoli. So we'll have the oxygen exchange in here. Is that right? So when we have the oxygen exchange during exercise, we said our pulmonary flow increased, our dead space decreased. So we use an equation to look at the dead space, okay? And this can be used with the cardiac and with ventilatory limitation. Why is that? It's a combination, is that right? It depends on the heart, the right side of the heart, the pulmonary vessels, and the alveoli. So if I have a problem in my airways, then the dead space will stay up, but my flow is normal and it went up normally. Or the opposite, if my airway is good, but I have a pulmonary hypertension or right side heart failure, the flow will not go up as expected. So this is a mixed problem between the lung and the heart. Clear? All right. So there is an equation called the VD-VT equation. Most of you as a pulmonologist should know it. Okay, if you didn't know it before, you should know it today. So the VD-VT equation, which equal 1 minus constant, which is K times VCO2. What's VCO2? And we have it in the test, is that right? And then PaCO2, which is the carbon dioxide in the artery, times the ventilation. So all of these parameters, we have it in the test. But wait, we said some people, they didn't do ABG in the test. Is that right? So if I do ABG, I have the PaCO2. Done. I have it during the beginning of the test and at the end of the test. And that's very easy to put the numbers. I have the VCO2, I have the PaCO2, and I have the minute ventilation. I put the number there and it will give me the ratio. Is that right? But if I don't have it, how can we estimate that? That's right. So Rami said like it's the entitled CO2. So I can use the entitled CO2 to like put it in the PaCO2, and I can use it as like just an estimate. Usually it should be around the same as the PaCO2. Okay, but in our testing here, we do an ABG. So you can use it, but if you could not do an ABG, so you can estimate it by using just we call the PIT CO2, which is the entitled CO2. Okay, and that number, I will show it to you. It's reported in the report as well. All right. So if you look at, I don't know, like, because different, I think different software. So my plan was to circle the VCO2 over the VO2. So if the VCO2 over the VO2 increase, what will happen to the V2? So what will happen? So VCO2 over VE increased, and there's one minus. So if this is increased, Rami said, and all of you said it will decrease. So if we think about it, if the VCO2 over VE increase, what will happen to the VD-VT? Will decrease. If we do the opposite, instead of VCO2 over VE, we'll make it the opposite, VE over VCO2. So what will happen to the VD-VDT? Will go up. Is it clear? Good. So Shane, clear? So if my VE-VCO2 went up, means that my VD-VT is going up, or the opposite, okay? What's the normal VD-VT during rest? The normal ratio? 0.4. And if I start exercising, what should happen to my dead space? So the old number like the old ratio. So if the VD go down, like, so put your mind, like the VD go down, so the VD-VT result will, that's right. So the VD-VT with time should goes down during exercise. Usually it goes from 0.4 to 0.2. That's normally. So as well as the VE-VCO2, is that right? It should go down. So the number we look at, so when we go back to the test, it's called the ventilation perfusion scan, part. We have the VD-VT and we have the VE-VCO2. So the VE-VCO2, we look at it, and the VDT as well. So when you look at it at 80 during anaerobic threshold, there's a specific number that we look at. This should be less than 34. So during VE-VCO2 during 80 has to be less than 34. But stop. I don't want to be like just like memorizing things. If it's not less than 34, it is more than 34, then what does that mean? Is that right? So we talked about physiology in here. So if I have increase in my VE-VCO2, means that VD-VT is increasing, there's two options. There is the dead space did not go down, or it did increase, which is abnormal. Is that right? It should go down. Or the flow from my pulmonary artery, it's not sufficient. Then that can tell me this could be cardiac or lung. That's why CPET is not one value. I'm going to look at the other problem to judge if this is a cardiac or lung. All right. So, any questions? That's the cardiac part. I hope it's clear. Clear like mud, confused.
It was all clear until the last slide.
No, that's good. Yes. We still have time. All right. So I'll go over it again. Okay. And stop me anytime. All right. So at the beginning, that equation, it came from different equation, which is the ventilation, the VE equation. Okay. And we cannot write in here. Sorry.
So the VT stands for ventilated dead space,
That's right.
and the VT is the ventilated tidal volume.
Yes, the normal tidal volume.
You're getting how much of your tidal volume is actually not participating in gas exchange.
That's right.
Okay, so ideally, when you start exercising, your dead space should go down. So the ratio of the gas that you are, the air that you're taking from the tidal volume that is participating in the gas exchange goes up, and the one that is participating in the dead space should go down.
That's right.
That's why your VCO2 ideally should go up, because you are doing more exchange.
And
Your
the ventilation.
should be going up, and the PaCO2 is going to be variable depending on which part of the exercise you are dealing with.
Good.
Now I understand.
Okay. Any questions? Clear? Kareem?
And you
Katabi?
calculate this one towards the end.
Yes, like at the at the AT and at the end of exercise. At the anaerobic?
And the maximum.
Okay. So if my in a one sentence, how many ml of volume I require to wash out CO2? Okay. How many ml of volume? Like if I have I need to have only one small breath to wash out a lot of CO2, my lung is working very good. And my blood supply is working very good. If I require a lot to wash out the CO2, there's something wrong. That's the easiest way to think about it. How many ml required to wash CO2, okay? So if I need a lot of ventilation to wash out the CO2, there's two options. That my dead space is big. I cannot wash the dead space. It's still in there. I need to have more effort to wash the CO2, or I don't deliver enough flow to the lung to do the washing. Okay? And this is very important in diagnosing pulmonary hypertension and as well as other lung disease. And when we finish the whole thing, in parts, you will see how easy you can interpret CPET. It's easy if you understand physiology.
So in the report, so the ratio, the upper ratio is inverted for the equation.
So in here, it's VE over VCO2.
So the VDVT should go we calculated the opposite way.
So VDVT and VE VCO2, they should go the same way.
Yeah, they should go together.
Yeah,
And
if this is high,
instead of going opposite to
which
each
it will
other,
be more difficult for your interpretation
so
and
then you
everything.
should switch it so that you should see them going together.
Yes, so if your VE VCO2 is going high, going down, which is the normal, it should go down. So, and it's less than 34, it should be less than 34. That's normal. So your VD/VT should go down as well. I don't know why I don't have the. Can I have your? Here. So just pass it. The first row, it has the VD/VT, and look at it at rest and at 80. So we said at rest should be around 0.4, and it should go down to 0.2. So the VE VCO2 is going down and the VD VT is going down, and that's a normal thing. So looking at the cardiac parameters, this patient has normal all cardiac parameters. But we said at the beginning of the test, the VO2 was low. So there is something wrong.
LV or RV dysfunction for the purpose of this lecture so far.
All right. Any questions? So like the target is try to look at, like when you have patient have done CPIT in your clinic, look at it. It's not the end of the world if you look at something that you don't know how to interpret, and try to interpret and try to do your best to interpret. And if you can't, like if you even do it wrong, then like stop me anytime, like, hey, Dr. Megri, this is the CPIT. I looked at it and I have a copy of it. Can we please go over it together? I think this is this and this and this and this. Even just the heart parameters. If you would like to do the others that we didn't talk about, it's still good, but like you will learn every time you do a mistake, you will learn from your mistake. Is that right? All right, Mina, any question? All right, thank you guys. Zoom ward, any question? There's no one in the. Okay, we're good. So we'll try to do like it will be like 3 parts. We'll try to do like repeat the exercise part